Right. So this is again in pen ankle. So in a diabetic, let us say uncontrolled diabetes of around 60-year-old female with ankle fracture, with not very healthy kind of a skin condition. So what would you like to do? Do you like to fix it as any other trauma versus do you want to do anything different like external fixator or directly take where it is in a kind of scenario?
Patient who's got some features of neuropathy, okay, then there is I'll be in strong consideration for a primary fusion in that scenario. Okay, but if he is a reasonably controlled diabetic, okay, as the good blood supply to the ankle, no evidence of neuropathy. Then, depending on the fracture, I might fix it, okay, but I will have things in mind that things can go wrong, so I will be getting a more robust fixation, okay, and probably delaying the repairing as much as possible, okay, if that is feasible again.
Yeah, so I think there's a message. What we need to tell is that ankle fractures in diabetics and non-diabetics are two different kettles of fish, and we need to separate these two in terms of the treatment plans. So robust, rigid fixation is what I was about to say, so Ashok said robust, and then definitely delay weight bearing. And be looking for signs of healing before I would allow them to start moving the ankle, but delay weight bearing. And then the complication rate is much higher, so I would definitely counsel these patients for much higher complication rate than a non-diabetic. Diabetes, smoker, ankle fracture, these three things are nightmare for me.
I think we have to look at the concept of looking into neuropathy is very important when you look at diabetic ankles or diabetic foot injuries. That I think people should start looking for it. Otherwise, if you just look at the X-ray, I think you will land up in trouble in such patients.
And India being the so-called diabetic capital of the world, we have so many diabetic patients. And osteoporosis, again, he said a 60-year-old female.
Yeah.
Another osteoporotic factor to take into consideration. So these are not simple fractures. These are fractures which we need to take it seriously.
So as you have put rigid or robust, I would say it as double the fixation, double the limitation of double the complication.
So I think that's a very important point what Ashok has raised and Ashok also raised.
One, you can start from superficial to deep or deep superficial. Skin condition is crucial. Glycemic control, then your bone quality and your stability of the fixation, delaying the weight bearing. I think these 4 points we have to nail it, and even with all these efforts, it may not go on to heal. That is the crux of the problem.
Always these cases what you are talking about is very tricky, because considering the age, you have suggested the patient age is 60. 60 I think still can be considered as a young, where you cannot sacrifice their joint. Because always just for an ankle fracture, if you tell them because you are a diabetic, I'm going to give you a fusion because I may fail. Many people may not accept. Even if we are in the scenario, we may not accept. So the prime point which comes here is the counseling to the patient regarding what they are. So what is the implication they are going to happen? Because if that is a trimanular no, he may eventually land in a chat put even if you fix it also sometimes. Some people will go, some people will not go. So that is where the Adelaide score is there. Depending on that, we'll decide whether we need to go for a fusion or a fixation. If we are going for a fixation, then definitely we need to tell them all the concepts what we have called a double. And the thing is, the patient should be understanding what he is having with his leg. It is like a bomb. It can anytime convert to a blast, or it can carry away with his life. So anything can happen, which he should be understanding. That gravity of the situation, if they take it, then it is done.
Whatever you said, I agree 60 is young, but if I'm dealing with neuropathy, so the young is old.
Yeah,
I think that is what should drive our.
I think everybody has to look at age, and just not the diabetes. You have to look for the neuropathic part of it, which is settled or not.
Right.
Is he having that? So that is when one of the indicators for you to decide which way you want to.
The
Yeah, I think for any fracture nowadays, I start looking at that number, 65. Yeah. So just physiologically is more important than the chronology. That's any fracture.
And one more thing is when we are talking about this super construct. So in a fibula, normally in any other bone we take a super construct as adding 2 plates or 3 plates or a nail with a plate. But what is that in an ankle?
Go across to the tibia.
Yeah, put all your screws from across the fibula into the tibia, like all syndesmosis. So that will give us a stronger hold and hold it. And one small tip is when if you are putting such screws, there should be 4 vortices. Because in future if they break, we should be able to deliver it from the other side.
Otherwise, not only we talk about spanning fixations across the ankle and then we will do it later.
Spanning, I think it's.
Yeah, that's okay.
Just like a
fixation.
Yeah, right.
Spanning.
Okay. This does done well. So this
Problem with the ankle is the moment you span it, it is stiff.
no, I'm asking you. I have not done it. Okay, because that's what we thought about the risk. Yeah, but
Paper actually on this, but where we have done it nailing without preparing the joints.
yes. So that we do
That's
as
the
well.
nail, and after once the bones have healed, they remove it.
That we do as well, but we are doing but like
They have
I'm not happy about it.
You know, we are very dome is.
So but like we did. So I was asking. So like the risk ones and then really.
Yeah.
Like, even if you span them for 12 weeks, nothing happens. They do.
The thing is in ankle, if you are spanning it, we have to distract it and span. Anywhere in the wrist also, the distraction is the key. Because unless we distract a joint and span it, the later on will not get the movement. In ankle, to distract it is a difficult task. Because you are fixing the trimass,
Probably the Achilles is another besides
Achilles and the anterior talus.
Anterior talus. Anterior talus, you have to bring them down. Yes.
We recently started doing some anterior buttress fixations for the elbow for shear fractures. Our results have been really good in terms of maintaining traction. But like we had to go ahead and remove some of those plates. 3 months. They have done well as well.
See you all at OTS 2026.